Hello, everyone. Thank you for joining us today. I'm Jenny from Education team at Medit. Nice to meet everyone. And today we have Dr. Michel here.
Hi, Jenny. Hello, everyone. It's
Hello,
nice to be
doctor.
with you in Minute.
How are you?
All good. You? Are you
Oh,
doing
I'm
well?
doing great. Thank you for asking.
Okay, that's great.
Have you made any plan for a new year, even though it's half a quarter of the year has already gone?
Yes, planning to travel.
So you're planning to visit IDS, is it?
Yes, of course.
Ah,
Visiting the IDS, yes, will be great.
ah, that's a big conference.
Yes, it is a very big show every 2 years for the most of the companies of dental market.
Hmm. What kind of machine or topics that you're interested in ideas to see?
Actually, all about digital dentistry and
Mm-hmm.
implants to see what's new about implants. I think we will see robots doing implants this year.
Really?
Yes,
Wow, this story is so fast. Please let us know next time about ideas. What have you
of
heard?
course,
What
of
have you
course, I will
seen?
do a review about it.
Thank you. Okay, so let's talk about today's topic.
Yes, today we have a basic webinar,
Mm.
planning your first implant, and this is a guide for everyone starting to do first implant ever. So some tricks, some ideas, some guidelines. This will help a lot for basic knowledge of
Mm.
implantology.
I think it will be a great chance for the beginners, right?
Yes, it's actually for beginners, juniors
Mm.
looking to start putting an implant. So some info to know about will help a lot.
Okay, that seems really interesting. So should I get started, doctor?
Yes, I'm ready.
Okay.
Big welcome to everyone joining us today. Welcome to this Medit webinar. I'm Dr. Michel Magdi Munir. We have a very nice topic today about planning your first implant. As you can see, it's a topic for beginners. We will talk about a lot of tips and tricks for doing successful implants in your early stages of implant dentistry. Before starting, let me introduce myself first. I'm Dr. Michel Magdi Munir. I am a digital implantologist, key opinion leader of multiple companies about implants and about digital dentistry. And I'm very interested in teaching young dentists about digital implantology. So, starting our topic today about digital implants, let me ask you a question first. How to reach success in implants? If you want to reach success in implants, you have to think about three main factors: osseointegration, functional aesthetic prosthesis over the implant, and healthy soft tissue seal around your restoration. These are the main factors that will help you get a successful implant with an overlaying restoration, whatever, a crown or another restoration. So, placing your implant, you should think first about some guidelines for the position of the implant inside the bone, with the relation of bone and with the relation of adjacent teeth and adjacent implants. For example, when you are placing the implant next to a tooth, your implant should be at least 1.5 millimeters away from the adjacent tooth. And if you have another implant proximal to it, it should be at least 3 millimeters away. So the minimum distance between two implants is 3 millimeters, and the minimum distance between the implant and the adjacent tooth is 1.5 millimeters. Also, you should think about the thickness of the bone buccal and lingual or palatal to the implant, which means the minimum thickness of bone is 1.5 millimeter of bone thickness buccally and lingually to the implant. So you can choose the proper implant diameter according to these data to help you get the proper implant size. As general rule, the size of the implant for the anteriors, which means the incisors, is around 3 to 3.8 millimeters. It varies according to the tooth and the size of the bone and the size of the jaw. When you go to the canine and the premolars, it varies from 3.8 to 4.2 or 4.5 millimeters. And when you go backwards to the molars, the minimum thickness is 40 millimeters up to 5.5 millimeters or even bigger if you have bigger jaw bones. So now that you can measure your bone and measure your implant, you can easily plan the size of the implant or the diameter you are going to use in your case. If you are having multiple implants and you have a long edentulous span like this one, you are going to calculate the total diameters of the implants and the total space, as we said, between each and every implant 3 millimeters, and the 1.5 millimeter between the most mesial implant and the most distal ones. So it is important to do such planning before starting your case. Now let me show you this case. This was one of my early ones, one of my very early cases. We have here two crowns retained on two implants, the lower second premolar and the lower mandibular first molar. Initially, they look okay. The soft tissue seal is not that perfect, but they look fine. But if you take a closer look, you will find out that there is the screw channel emerging from the crowns from an unfavorable position, which means that the screw channel is not emerging from the central fossa. It is emerging from the distolingual cusp. And this is not what we really want to do. If we take a look here at the periapical radiograph of this case, you will find that the direction of the implant could have been placed better than this one. As you can see, the long axis of the implant is not centralized in the central fossa of the crown. So it was to be done better than this by placing the implants a little bit tilted so that the pulse of insertion will be centralized under the crowns. That's what we call a prosthetically driven implant. Prosthetically driven implant means that you plan your prosthetics, your prosthesis, your crown first, and then you put the implant centralized under the crown. You can see here that we have a triangle for successful implants, which we call the implant triangle. It consists of a prosthetically driven implant position, sufficient bone surrounding the implant, and healthy soft tissue seal around the crown. These are the three parts of the triangle which will give you success for your implant crown restoration. That's why you need to do digital implant planning. And by saying digital implant planning, I mean that you have a CBCT, a DICOM file, a planning software, an intraoral scan with you from your MEDED device, and you start putting the future crowns and then adjusting the position of the implants according to the future crowns, not the opposite. which means that when you take a look on the X-ray, on the CBCT of the patient, you don't search for the good bone dimensions and place the implant, and then later on you will face trouble with the future crown. We start by planning the crown first. That's why we call it prosthetically driven, and then we adjust our implant to the future crown. As you can see here, I planned for 2 mandibular molars, the mandibular first and second molars on the left side. I planned the crowns first in this case, and then I placed my implants according to the crown position. So when I placed the implants in the patient's mouth, the end result that the crowns will have a screw channel coming from the central fossa, not from the buccal or the lingual aspects. You have to do bone assessment then for the bone available under the future crown. And is it enough to accept the implant or not? Is it having enough bone in all aspects surrounding the implant or not? For example, in such case, I got a patient in my office with a remaining root of an upper second premolar and seeking extraction and implant. When I took a periapical radiograph like this one, I thought that it would be easy to do it immediately. Extract the root, immediately put the implant in place. But when I took a look on the CBCT, I found out that there was no enough bone apical to the root to place my implant. So I decided to do this case delayed. I decided to extract the tooth, just put some bone graft to preserve the socket, and later on, after 4 months, I started putting the implant in the place of the bone I restored. So the position of the implant will be surrounded by bone in all aspects. And of course, after the osseointegration phase, I took the scan with the scan body over the implant, and I started fabricating my crown, which looked like this. As you can see, the crown is prosthetically having nice screw channel in the central fossa, and we can say here this implant is prosthetically driven with enough surrounding bone in all aspects. And that's how it looked in the patient mouth in occlusion. So the key here was planning. Planning after taking a look on the scan using the MEDET intraoral scanner, and also after inspecting the CBCT DICOM file and the amount of bone around the root. What about doing anterior implants? Actually, when you are working in anterior implants, you have to think a lot about the future aesthetics of the crown over the implant, and of course the soft tissue profile. We have serious cases like these ones with patients coming of failing old posts and cores and crowns with remaining roots that are not restorable. So to assess such cases, we have Dr. Dennis Tarnow classification. He classifies the sockets of anterior teeth into 3 types. The 3 types of anterior sockets, mainly inspecting the labial plate of bone and the labial soft tissue. The type 1, or the first category, having enough bone thickness in the labial plate and having enough soft tissue labially. this is what we are dreaming of. This is a very easy case to restore because when you are going to extract the remaining roots and put your implant, you are still having enough labial plate support and labial soft tissue support. So if you place an immediate temporary crown, maintaining the profile, the perimeter of the gums, you almost finished your task. But in more difficult cases, like the type 2 and the type 3, in type 2, you have lost, or the patient already has lost, a part or a big part of his labial plate of bone with maintained soft tissue without gum recession. In this type, the patient has no root showing in the oral cavity. He has no gum recession with root showing. But in the CBCT, when you inspect the labial plate, you will find that a part of the labial plate was lost. So in this case, you have to take care. After extracting the root, you have to put bone graft and membrane to support the remaining soft tissue. If you leave it without graft and membrane, the soft tissue will collapse. In harder cases, like the type 3, the patient has not only lost the labial plate of bone, but also the soft tissue has recession. There is gum recession, and a part of the root is showing in the oral cavity. In such case, you are looking forward to rebuild the bone, so it is advised here to do a guided bone regeneration to build up the bone using a bone graft and a membrane, and then putting your implant delayed later on after building the bone. There is another technique, as you can see in this case, which is called partial extraction therapy, PET, which consists of leaving a part of the labial plate for type 2 classification of roots. This part of the root canal treated root is left on the labial surface, supporting the remaining soft tissue, preventing further labial plate bone loss. This is a little bit an advanced technique, but you should expect it as one of the solutions to preserve the labial soft tissue without recession. The important factor about anterior implants is the position of the future screw channel. You have to always have your future screw channel over the implant emerging from the future cingulum of the crown. So the anterior implant angulation is affected by the direction of bone or the tilt of bone in the anterior area. If you have a straight bone in the anterior area, your implant position will be very favorable to place a crown screw retained with a screw channel emerging from the cingulum or the fossa of the anteriors. So placing a screw retained crown here is the optimum solution. But if your bone is a little bit labially tilted, you will have to search for other solutions. The first solution will be going for an angulated screw channel, which we call a dynamic screw channel. Some implant companies have this feature of providing a dynamic screw with a dynamic screwdriver to get a screw channel that is angled 10 to 15 degrees from the initial screw channel of the implant, from the long axis of the implant. The other solution is using a custom abutment, and a custom abutment here can be titanium or zirconium. The titanium abutment disadvantage that it may have a bluish discoloration in the final crown because it's a metal. And of course, the other disadvantage here is that you are going to place your crown cemented over the custom abutment, not screw retained, So there is some disadvantage for a cemented crown, mainly retrievability, that a cemented crown is not easily retrievable as a screw-retained one, and also a risk of excess cement around the cemented crown may cause peri-implantitis in the future. That's why we always prefer to do our cases screw-retained if possible. If it's not possible, you will have to be careful about putting a cemented crown over a custom titanium abutment or a custom zirconia abutment. Well, so facially tilted implants, first choice 10 to 15 degrees is angled screw channel. Second choice is a zirconia abutment with a cemented crown over it. And the last choice will be titanium abutment custom one with a cemented crown over it. Let me show you a case here having an upper canine implant, facially tilted. I also had two crowns over first and second premolars. Now, for this case, I did a custom titanium abutment, then a cemented crown over it. You can see in the clinical picture here that the canine, which is a crown cemented over a custom titanium abutment, has bluish discoloration compared to the first and second premolar crowns. That's because of the underlying titanium metal abutment, which has a metal display under the crown. Even in zirconia and even sometimes when you use opaque cement, still it is different in aesthetics. It doesn't give you the best aesthetics. So that's why this one is our last choice. And also, when you are using an angled screw channel, a dynamic screw channel with a dynamic screwdriver, here you should take care of something very important, that after you have the crown milled or fabricated, before cementing it to the tie base, you have to put the screw inside the tie base first, before cementing the crown. Because after cementing the crown, it is impossible to insert the screw. Why? Because now our screw channel is angled, part of it in the crown and part of it in the implant with different angulation. Now let me show you a case of a dynamic angled screw channel. A patient presented to my office with an upper canine, periodontally affected, having mobility and bone loss, and she was seeking to restore it by an implant. So after doing my plan, I found out that I have a 15-degree angle between the implant direction and the future proper position of the crown. So after I placed my implant and after the osseointegration phase, I started creating a custom emergence profile, as I'm going to show you in this webinar how to do it. And I fabricated my crown with a dynamic angled screw channel so that the screw channel may come out from the lingual aspect of the incisal edge, not from the tip of the incisal edge of the cusp tip of the canine or the labial surface. This is the scan using the scan body, and this is the final crown having a dynamic angled screw channel with a 15 degrees. It looked like this in the final result, and that's how the crown looked clinically, and the patient's smile was restored successfully using an angled dynamic screw channel. Also, we have to think of the anterior implant's depth, the position of the implant, how deep inside the bone. Now, the margin of the soft tissue should be measured from the mid-facial point, and your implant platform should be at least 4 millimeters deep from the mid-facial free gingival margin to have future space to create the future emergence profile of the soft tissue. So you have to be careful of the biologic width around the implants. We define the biologic width around the implant as the 3 to 4 millimeter distance from the top of the peri-implant mucosa to the first bone to implant contact. This part is the biologic width around the implant, and you have to respect it without any violation. For the posterior implant's depth, how deep are you going to place your implant inside the jaw bones? Well, it depends on the interarch space and the available bone space. Let's take a look on this case. It was a very difficult case. The patient presented to the office with a lost bridge on the canine, the first and second premolars, and also a broken first and second mandibular molars, badly broken and badly damaged, that cannot be replaced with a crown or a post or any restorative work anymore. You can also notice that she has severe bone loss and soft tissue loss at the area of the first premolar. We took a periapical radiograph. We found that she had a nice long root for the second premolar, but the first and second molars had fractured roots. We talked about doing a GBR, a guided bone regeneration, for the first premolar, but that was not an acceptable option for her. So we decided to go for a new bridge for the canine, the first and second premolars. While for the molars, we had to do extraction and planning implants. But we had a surprise that when we took her the initial scan, you can see that there is no available interarch space to place crowns over the future implants because of the over eruption of the opposing. So we had to find a solution for this case. So after planning, I found out that I could place my implants a little bit deeper inside the jaw bones and trimming my interseptal or interdental bone around the implants to give room for future crowns. This is how the implants were placed deep inside the jaw bones, and bone graft was placed after trimming the bone to surround the thread of the implants and left to heal using a gingival former. After the osseointegration phase, now I have emergence profile for both implants, and I have enough interarch space to put my crowns. So I took the scan using the scan bodies, fabricated the crowns, and put them in place. So now my question is, what is the minimum crown height in posteriors? What is the minimum acceptable to do a crown? I mean the distance from the implant platform till the occlusal surface. The minimum available thickness should be 7 millimeters, not less than 7. And by saying 7 millimeters, I mean the distance from the implant platform till the occlusal surface. If you have less than 7, you should consider placing your implant deeper to get enough room for the future crown over the thigh base. Also, a very important factor for implant success is proper soft tissue seal around the crown. You can see here, in this case, having an implant crown over a first premolar with excellent soft tissue profile, with excellent soft tissue seal around the implant crown. This will give longevity of the restoration and proper health around the implant crown system. That's why we take care while we create emergence profile over the implant. And we have what we call EBC zones of the emergence profile, which means that the soft tissue emergence profile over the implant have 3 zones. The first zone is the aesthetic zone, which is the critical zone. And then the deeper zone is what we call the bounded zone. It is less critical zone. And the deepest one is the crestal zone. It also a less critical one. So we have the EBC zones, the aesthetic critical zone, and the non-critical bounded and crestal zones of the emergence profile. So after the osseointegration and the healing phase, a creation of a proper emergence profile will give you proper seal of soft tissue around the future crown, around the implant. This is of prime importance of doing proper seal around the implant. Sometimes you have to do a custom healing abutment over the implant because a lot of companies only have rounded small gingival formers that are not suitable for all types of teeth. They may be suitable for anteriors, but for posteriors, doing a custom healing abutment is a lot more beneficial. As you can see here, if we are having a molar with a rounded emergence profile, this one will not be suitable very well for the crown. If we could do our emergence profile bigger than this rounded one with the shape of the molar, it will give us much better emergence profile. For example, in this case, we have a badly broken remaining root of an upper first molar. We planned to do extraction and immediate implant over it. This is how the remaining roots looked like in the radiograph. We separated the roots, extracted every root separately. And regarding the sockets of the posteriors, we have also a classification for the immediate implants in posterior sockets. The classification is of 3 types. The first type is having enough bone accepting the implant in the interradicular area with all the threads of the implants completely surrounded and covered by bone without any threads exposed. That's what we call a type 1 posterior extraction socket. A type 2 posterior extraction socket is having enough interseptal bone interradicularly to accept the implant, but some of the implant threads will be exposed in the socket. In such cases, after placing your implant, you have to surround it with some bone graft to cover all the threads exposed. The type 3, or the last one, is a wide socket with no interradicular bone for implant stabilization. Your only solution here is placing a bigger implant diameter so you can engage the inner aspects of the socket walls for primary stability of the implants. Our case here was a type 2, which means that after doing my osteotomy and placing my implant, some of the threads of the implant were exposed in the mesiobuccal socket and in the palatal socket. So I had to put some bone graft in the socket, and after putting my graft, I did a custom healing abutment using a silicone rubber index. The silicone rubber index is available over the market. You can find many types of it. It is shaped according to premolars, molars, and anterior teeth. You pick up the size of the tooth desired. You put a temporary abutment inside, and you inject composite around it so that you can create a custom healing abutment using a temporary abutment and composite. And when you put it in place, if you inspect it and find that there is still gap between it and the soft tissue, you will have to add some composite. As you can see in this case, you have a gap. We will have to add composite here to close the gaps and have a seal using the custom healing abutment touching the soft tissue. This will give us a very nice emergence profile in the future for our crown, and will give us very good maintaining for the emergence profile of the soft tissue, so that our future crown will be nicely formed and prosthetically driven, of course, with the screw channel emerging from the central fossa like this one. It is always preferable to do custom healing abutments whenever possible to shape your future emergence profile according to the shape of the tooth restored. It gives much better results than the stock gingival formers or the stock abutments. Also, in some cases, you may have to use, after putting the bone graft, a complete temporary crown, not only a custom healing abutment. You can place a temporary crown like this case, where I placed the implant, the bone graft in the socket, and then a temporary crown to get me an emergence profile for the final crown. Now, comparing your restoration, a screw retained restoration or a cemented restoration. I always advise you to do a screw retained, not a cemented restoration. It has two main benefits. The first one is retrievability. As you do a crown screw retained, you can easily retrieve it and adjust it and clean it, maintain it and putting back in place. And also you will skip any excess cement around the crown, which may cause any peri-implantitis in the future around the implant. Now, to finalize, I will give you 5 take-home messages from this webinar. These 5 take-home messages are guidelines for placing your first implant. The first message is that the soft tissue seal is the main defensive mechanism against peri-implantitis. Always give special care to proper soft tissue seal around an implant crown. Message number 2, the thinner the soft tissue, the deeper the implant is placed to get enough room for the emergence profile. Always take time to assess the soft tissue of the case, measure it. If you have a thin soft tissue, you will have to place your implant deeper. We have a rule which we call the rule of 4. The rule of 4, if you have 4 millimeter thickness of the soft tissue, you will place your implant at the bone level. If you have 3 millimeter thickness of soft tissue, place your implant 1 millimeter deep. If you have 2 millimeter soft tissue, place your implant 2 millimeters deep in the bone. So the rule of 4, that the level of the soft tissue, the highest part of the soft tissue should be 4 millimeters away from the implant platform. Message number 3, in post-extractive immediate cases, where you extract the root and put the implant immediately, you have to always maintain the socket perimeter by fabricating a custom healing abutment. Do not leave the implant exposed to the oral cavity, and do not leave it to collapse the perimeter of the soft tissue. Preserve it by a custom healing abutment. Message number 4, preserve the labial plate in anterior implants by partial extraction therapy or dual zone grafting, putting bone graft in the dual zones labial and parietal to the implant, and immediate temporization using a temporary crown. Message number 5, plan the screw retain crown on digital planning software, then adjust the implant position accordingly. Start by putting the plan of the crown first and then the implant under the crown. Always do it screw retained, not cemented. I always like to say, no cement, no cry. Okay, that was all for today's webinar. Thank you for joining us, and let's take a look if we have any questions today.
Okay, thank you for sharing your clinical tips. It was very informative.
Thank you so much. I hope you enjoyed it.
I really enjoyed the basic part of the implantology.
Yes, basic knowledge, yes.
Okay, so let's move on to Q&A sessions.
Yes, sure.
Today, we have 4 questions. So I will start with the first question.
Okay.
Question number 1. What do you think is the key part when planning an implant treatment?
Well, the key part is having the final crown or the restoration in mind. That's what I talked about, the prosthetically driven implant, because it is always preferable to put the implant centralized under the future crown, not putting the implant according to the available bone and then having trouble later on with the crown. Because actually the patient is coming to the office for a tooth, not an implant.
No, that's
So
right.
it's better to plan the tooth first and then adjusting the implant to the planned future tooth. So the key part is working what we call prosthetically driven.
Okay. Okay, next question. Question number 2. What is the most important factor to consider when giving advice to a dentist who are new to implant surgery?
Well, the most important factor to consider is working according to a plan. Give a lot of time to plan. Never ever start a case immediately after doing all your homework, taking an initial intraoral scan with your scanner, doing a CBCT, doing a planning on a 3D planning software using your data. So spend a lot of time in planning and less time clinically. So the most important factor is planning.
Okay, I think it's really important thing that you just
Yes.
said.
Yes, when you spend a lot of time in planning, you save a lot of time chairside.
Okay, next question. Question number 3. What aspects should beginners practice to quickly improve their implant surgery skills?
Well, to improve surgical skills, practicing suturing is very helpful in the beginning. Everyone should have some practice, mainly not on the patient, extraoral, on dummy silicone, or even orange peel. You can practice suturing techniques, different types of sutures, because ending your surgery with proper suturing is very important. So a lot of clinicians place the implants in the early phases very easily, and then facing trouble closing the suture or the wound. So practicing suturing will be very helpful for beginnings. There are in the market different silicone, plates with different types of sutures. So every beginner should practice a lot suturing techniques and study different types of sutures. This will help a lot to save chair time.
Okay. Okay. Next, the last one. Question number
Okay.
4. What would you like to say about using surgical guide to dentists who are new to implant surgery?
Well, of course, using a surgical guide is very important in the early phases because when you don't have enough skills and enough experience, using a surgical guide will help you a lot, placing the implant in the desired position exactly, according to the mesiodistal centralizing position, buccolingual position, proper angulation, distance from the adjacent tooth and the adjacent implant. But also, I would like to add that the surgical guide is just a help tool. Do not depend 100% on the surgical guide because a surgical guide may be seated not 100% well, maybe 95%. This will cause a little difference. And also, you have to take care that your surgical guide doesn't prevent the irrigation from reaching the bone. Because if you are using the closed type of the surgical guide, this may prevent the irrigation to reach the osteotomy site, the bone properly, and which may cause a lot of heat generation. So it is always preferable to go for the open type of the surgical guide. And if you are not going to use the open type, you are going to use the closed one. So you have to add extra irrigation, extra coolant to prevent heat generation.
That was really a clinical tip. Hmm.
Thank you.
So do you prefer to use surgical guide at your stage, or do you like to place implant without surgical guide? You're like a master, so what do you
I
prefer?
actually do it freehand.
Mm,
Yes, in most of the cases, I work freehand, but in very, very critical ones,
mm-mm,
I do the surgical guide to help me, but not on a daily basis.
You just
Because
use it in difficult cases.
yes, because I think that working without a surgical guide also will develop your skills
Mm,
because you depend on your hand, on your vision, on your angulation, on your positioning. But when you do with a surgical guide, and if you are used to use the surgical guide every surgery, if, for example, after a while, your surgical guide is not fitting and you have to work without it, you will face a real problem.
mm. Hey, that was really real advice, right? Mm.
Thank you. Hope you this info will help in doing the surgeries better.
Mm. Okay, thank you for answering all the questions with your experience and clinical tips.
Okay, thank you, Jenny, for this chance to be with you in this webinar. Looking forward to have many ones in the future.
It was nice to meet you again, and that's all about it for today. We'll come back with diverse topics and useful topic next time. So let us know any feedback or any topics that you are interested in. Thank you for being here, doctor.
Thank you, Jenny.
See you next
Goodbye.
time. Bye
Bye.
bye.